Good evening, everyone. Welcome to the next session of Journal Club in Image. And today we have St. John's is the host for the Journal Club. And we have Dr. Annie Kanchan Ba from St. John's. She's a medical oncologist who has done a degree, MBBS from St. John's, then post-graduation from Delhi, and then All India Institute. She has done her MD, DM Medical Oncology. And as you all know, the session is that we will have the Journal Club presentation, and we have the national expert, Dr. Hari Menon, and Professor Nupur Raje, who has consented to wake up early morning there, and she's with us from Harvard. And subsequently, we have the Eagle Eye competition, and that will be followed by the online quiz from the old-time favorite VA Arun. And for starting the session and introducing and starting, I invite Dr. Annie to start the presentation. Over to Dr. Annie.
Thank you, sir. Thank you for the invitation. And thank you for giving me this opportunity to present the Journal Club. Can you please make me the host so that I can share the screen, please?
Yes, ma'am, you can share.
My slides are visible?
Yes, ma'am.
Yes, go ahead.
Okay. So I'll be presenting a topic given today is talquetamab, which is a GPCRD directed bispecific antibody. And it has been, this is the phase 1 trial, the first in humans, and evaluated in a relapsed refractory setting. We have progressed a lot in terms of the therapy that we have, and there has been tremendous advances that we have seen with PIs, IMiDs, monoclonal antibodies. But despite these advances, our patients eventually relapse. So we always have to have another line beyond, third line and beyond, to do better for our patients. We have novel immunotherapies, monoclonal antibodies, and antibody drug conjugates, BiTEs, and CAR-Ts, which have helped give us a deeper response, longer survival, and also maintaining the quality of life of the patients. So a little bit on what are the ADCs and the BiTEs. What is an antibody drug conjugate? It's basically a combination of an antibody that is highly selective for a specific tumor antigen, and it is combined with a payload that is a cytotoxic agent, which is linked with this to the monoclonal antibody. And this internalizes and then causes the cytotoxicity. The improvisation of this is now we have the bispecific antibodies. It's an antibody that is targeting two receptors simultaneously. So one, what we see here is the T cell, our immune cell, and the other one is the tumor cell. So we have a lot of bispecific antibodies that are there in trials right now. The one that is of our interest is talquetamab. So coming to the article for today, talquetamab, which is a T-cell redirecting bispecific antibody for multiple myeloma. What is talquetamab? As I mentioned earlier, it is a bispecific antibody targeting the GPCRC5D receptor on the myeloma cell and the CD3 on the T cell. As a result of this engagement, it causes T cell recruitment, activation, and cytotoxicity, causing the death of the myeloma cells. What is GPCR5D? It's actually an orphan receptor that has been evaluated lately, and it's seen that it is highly expressed on multiple myeloma cells and also in hard keratinized cells in our body, and very minimal expression on the other normal hematopoietic cells. Also, one unique feature is that it has a 7-pass membrane protein. which leads to its protein shedding, which is comparatively lesser compared to BCMA. There have been studies that show that BCMA has increased protein shedding, leading to sync effect. This may be related to the gamma secretase activity causing increased protein shedding, and this results in reduced efficacy. This has seemed to be a little lower for the GPCR5D. And the expression of this G protein coupled receptor family C group D is independent of BCMA. Hence, it was a very good potential target for a relapsed refractory setting in patients, those who had already received a BCMA therapy. So what was this study? It's named Monumental 1 study, phase 1 open label multi-center study, where 288 participants were screened. Eventually 232 were enrolled for this. So the patients with measurable multiple myeloma, those who were relapsed refractory, or those who were intolerant to established therapies, with a hemogram that was hemoglobin greater than 8, platelets more than 50,000, and absolute neutrophil count of more than 1,000. So it had two parts here. That is the dose escalation part and the dose expansion part. The dose escalation part here, we see there was a step-up dosing that was incorporated. I'll explain later how the step-up dosing was. And this 0.5 microgram kg was the starting dose that was initiated. The step-up dosing was taken to mitigate the CRS percentages. And all of the patients were given glucocorticoids, paracetamol, and antihistamine before the full dosing was given. After the dose escalation, we found the RP2D, and then there was the dose expansion phase. The key objectives, as I mentioned, was part 1 was to establish the recommended phase 2 dose. The part 2 was to evaluate the safety and tolerability of bispecific talquetamide at the recommended phase 2 dose, along with the exploratory objectives were the anti-tumor activity, the pharmacokinetics, and the pharmacodynamic. The statistical design that was used was a modified continual reassessment method with a Bayesian logistic regression model, along with escalation with overdose control principle. And the descriptive stats were used to summarize the data. Overall, 230 patients were enrolled, 102 in the intravenous arm, given a dose ranging from 0.8 to 180 microgram per kg. And for the subcutaneous, 130 were enrolled, and the dose ranged from 5 to 1600 microgram per kg. This was the first dose escalation part. The 0.5 microgram per kg weekly dosing intravenously was initially started. How did we come with 0.5 microgram per kg? It was based on a MABEL dose, based on FDA and EMA principle. They had taken, based on the in vitro studies, they had come at the dosing of 0.5 microgram per kg. And then they had the safety, pharmacodynamics, and the pharmacokinetics data that was analyzed. And based on the Bayesian logistic regression model, the next dose was evaluated for the cohort. So in this way, the dose escalation was done till 180 microgram per kg. Simultaneously, they also saw that the PK, the pharmacokinetics level, showed that the T-half of talquetamab in vitro studies was close to around 14 days. That's how bi-weekly dosing came into picture, and they also analyzed dosing by monthly. They also saw that the subcutaneously they analyzed at 5 microgram per kg, and eventually 405 and 800 microgram per kg. This was given every 2 weekly, and 405 was given every weekly. This was taken as the recommended phase 2 dose based on the efficacy, safety, pharmacokinetics, and ease of administering the antibody. Because the IV was a 4-hour intravenous infusion, and every weekly giving, and along with the entire PD and PK data, the dosing of 405 and 800 micrograms per kg was taken as the recommended phase 2 dose. The next was the dose expansion part, where the 2 doses, the further patients were enrolled for it, 30 in the 405 arm and 800 in the 44 patients were incorporated for the 800 microgram per every other week. And these are the baseline characteristics of the cohort that was enrolled. If you see, this is the entire 130 dosing. The gist of this is majority had more than the median dose, the median lines of therapy received were 6, along with majority of them having triple class exposure that amounts to exposure to the PI, the IMiDs, and the monoclonal antibodies. And pentadrug exposure is 2 of the each therapy, along with 1 monoclonal antibody against the CD38. So if we dissect further and see the dosing of the characteristics of the 2 doses that were selected for the RP2D, we see here is the age is approximately 60 to 65 years of age, predominantly male, equally divided here, and the time since diagnosis 5.5 to 6 months, and the median lines of therapy that was received earlier were 6 before the talquetamab was administered. Interesting to note here is they are a heavily pretreated population. They had undergone transplant, and here we should notice how many of them had received prior BCMA-directed therapy in terms of CAR T cells also, and also a bispecific antibody. And majority of them had refractoriness present to proteasome inhibitor, IMiD, and the monoclonal antibodies. So coming to the safety analysis, these were the dose-limiting toxicities that were encountered. The grade 2 toxicity in terms of increased lipase level with the IV route, which improved with withholding the treatment. And majority were the skin rashes that were seen, and either the dose was reduced to the previous dose given, or the treatment was withheld and the toxicities had improved. The hematological toxicities that we're seeing is majority, if we see the grade 3-4 toxicities are hematological. They mentioned it as there were reversible toxicities, and generally during the step-up doses is what the grade 3-4 toxicities were noticed, both in the 400 microgram arm and also in the 800 microgram arm. The infections that we see was around 47%, and grade 3 to 4 were around 7% in each of the cohort. The non-hematological toxicities, the CRS, if we see, is 77 to 80% in both the dosing. And this was generally, which I'll describe later, was more in the first step-up dosing arm, which later on reduced with recurrent dosing. If we notice here, the skin, nail, and dysgeusia is seen commonly in both the arms. This is basically because of G-protein coupled receptor, which is present more in the keratinized tissue, leading to the side effects seen in this skin, nail, and having this dysgeusia. Then the other side effects that were seen were weight loss, pyrexia, diarrhea, dysphagia, transaminitis. The cytokine release syndrome that was seen, if you see here, it was ranging from 77 to 80%, and majority were during the first step-up dosing. The median time to onset was 2 days, lasted for about 2 days again, and about 76 to 80% had to receive supportive measures, out of which tocilizumab was administered in 63% in the 405 microgram arm. Otherwise, the other one had 54% receiving it, tocilizumab. And steroids, oxygen, vasopressors also had been used, but only in one patient each. The other supportive measures that were used were paracetamol and other supportive treatment. If you see the graph here, the grade 3 CRS that was seen it was only in the 405 microgram arm, and there were no grade 3 CRS events seen with the 800 microgram subcutaneous dose. Whereas in the intravenous group, there were 5% of the patients who developed a cytokine release syndrome. As I mentioned earlier, there was a reduction in the percentage of patients developing CRS when subsequent doses of talquetamab was given, and it dropped from 77% to around 30% in both the RP2D doses. The neurotoxic events that were seen was majority grade 1 or 2 in the subcutaneous cohort, and also during the initial dosing, they have reported these neurotoxic events. Grade 3 events were seen in around 3% in the intravenous cohort. The adverse events that were reported were around 43% in the 405 and 34% in the 800 arm. They've reported 3 fatal events: neuroendocrine carcinoma, sepsis, and basilar artery occlusion. However, the investigators reported it as not related to the talquetamab infusion. Coming to the overall response rates, we see that there was significant activity seen in the entire cohort of the subcutaneous arm and also in the intravenous. A slightly greater percentage that is seen. Overall observation, the median duration of follow-up was around 11.7 months in the 400 microgram arm and 4.2 months in the 800 arm. And we see that the VGPR response was greater than 55% in the 400, and this was close to around 50. These are the plots that demonstrate that as the patients receive subsequent doses, they had further deepening of the response. This is the bar graph showing responses over time for the 400 microgram cohort. So if you see here, there are patients, single patients here on the y-axis, demonstrating that it is a penta-drug refractory and a triple class refractory. Here, the black arrow in this denotes that they have continued treatment. And the dark green here demonstrates that they have achieved stringent complete response on continued administration of the drug. And the others here had progressive disease. So this is evident that with subsequent dosing, and patients have actually improved responses from a partial response to a stringent complete response in those who could continue the therapy. This is the 800 microgram cohort. Here too we see the median duration of follow-up was 4.2 months in this cohort. And we see that here too, with over time, the responses have deepened. Coming to the pharmacokinetics, that was one of the exploratory endpoint here. We see here that this is the 90% effective concentration here. If we see the crest and trough here in the intravenous route, the ratio is more as we compare to the sustained levels that are achieved by both the doses, the 405 cohort and also the 800. So because of this favorable activity, as I mentioned, the PK data favored a subcutaneous dosing. So because of this dosing, it was taken as the RP2D and the safety levels were comparable for both the arms. That's why it was taken as for the further expansion. In the pharmacodynamics, the PD-1 positive T cells were assessed. This is the box plot. If we see here, we see that there were T cell activation denoted by these dots here, which suggested that consistent induction of this immunogenicity was achieved by both the doses. So what conclusions do we draw from this trial is, it is a novel T cell redirecting bispecific antibody, and it's showing to be tolerable in heavily pretreated. That is, a median line of therapy that was received was 6. And both 800 every 2 weeks appeared to have comparable efficacy with the weekly regimen. There were no new safety signals, and subcutaneous administration was more patient friendly compared to the intravenous route, with the PK profiling allowing for the less frequent dosing. The overall response rates, even in the triple class and the penta-drug refractory, was close to around 70 to 70%. That is impressive, and which were durable and deepened over time. Overall, this is definitely a promising target for patients with relapsed refractory multiple myeloma. Thank you.
Thank you. Thank you. Thank you, Annie, for that presentation, and quite a detailed presentation regarding talquetamab. So here we are in an era of newer drugs developing, which is again having activity in what we perceive as refractory myeloma, and into the era of bispecific T-cell engagers, of which we have a new molecule with a new target over here. But to me, what is impressive over here is that there were some of the patients in this study who had also received CAR T-cell therapy, which was targeting the BCMA, and they also showed responses, probably because it's a new target, and we are able to exploit that effectively for getting responses. So, but probably the disadvantage is it is a continuous therapy that we need to go through with. But in this case, probably instead of the weekly regimen, we can move to a bi-weekly regimen, which may be a lot more easier on the patient. I mean, cost, etc., are different things that we have to look into. But we are having a series of all these BiTEs that are bispecific antibodies, which are for myeloma, starting from the anti-BCMA bispecific antibodies to those targeting the FC receptor homolog 5, and also now we have the GCRC5B targeting bispecific antibody. So still, again, something encouraging as far as myeloma is concerning, and as was true for the slogan for our 5th Congress, extending survival. We are able to extend survival again in myeloma too. But how meaningful that survival is, I would leave to Dr. Nupur to discuss on that and your experience on the use of these antibodies. Yes.
Yeah, no, thank you so much, Hari and Annie. That was a fantastic presentation. Thank you. You touched on all the big highlights. I think part of the reason to have this presentation is we are in the era of bispecifics. You all are about at your center. If you haven't already opened your studies with teclistamab, you're just about to open them. So learning more about these is useful. This was a classic first-in-human phase 1 study. It's amazing that the New England Journal of Medicine publishes first-in-human studies. Obviously, when you review a journal article, we talked about what's good about this, but it's really important to highlight some of the limitations of this study as well. I think, very large study, but end of the day, they focused on the RP2D, which is the recommended phase 2 dosing. And even there, they've come up with 2 dosing schedules, right? So typically when you use a Bayesian method, which is what they've used here, so number one, for a first-in-human study, the goal of the first-in-human study is to figure out whether or not the antibody or drug is tolerable at all. And the second step is, which is the phase 1B part of all of these first-in-human studies, would be to identify a recommended phase 2 dose. the intravenous versus the subcutaneous version is something we are struggling with all of the bispecifics. I think most of the bispecifics now are being used subcutaneously, except for those with very long half-lives. This one did not have a short half-life, so that was not the reason for switching to subcutaneous, but it was more so, and you showed very nicely the PK data. You showed the PK data where with the subcutaneous version, you have a more sustained exposure to the drug. There are no peaks out there. And by doing so, you're actually decreasing the incidence of toxicities. And the major toxicities, obviously, that they were concerned about was cytokine release syndrome. It's a nice study. They used a lot of patients, which I think is a huge negative to get to their recommended phase 2 dosing. It took them forever. The study started in 2018. It took them forever to get to those 30 plus 40, 80 odd patients who are in the recommended phase 2 dosing. I think the fact that they're targeting GPCR5D, which is a novel target, is a great thing. I think we need alternative targets. Hari's mentioned FcRH5 already. We need targets outside of BCMA. And the beauty of a plasma cell is it is antigenically very rich. We all know how many different antigens there are that we can explore. There's not that many which are localized to the tumor alone. This one specifically is expressed on plasma cells. What we don't know about GPCR5D is what is the function? What is GPCR5D doing? There's some data, and I think you highlighted that in your background, that high-risk disease might have a higher expression of GPCR5D. We really don't understand why that should be if it's present on all plasma cells. And to date, I don't believe we understand exactly what GPCR5D does in myeloma cells, whereas with BCMA, it was very clear, right? BCMA is present in all mature plasma cells, and it really does impact the survival of plasma cells, whereas GPCR5 is mainly a target alone. So using an antibody drug conjugate could have worked just as well. It could have caused a lot more toxicity. And you talked about the on-target off-tumor toxicity. With all of these agents, the on-target off-tumor toxicity becomes really important. And that is because it's present on keratocytes, it's present on all those tissues, specifically the GI tract, skin, nails, which is where you talked about the dysgeusia, the nail changes, the skin changes. And I will tell you that those are not trivial, right? You saw that 70% of people, give or take, depending on what dosing you looked at, they ended up with these side effects. And unlike CRS, and there was a question out here about CRS as well. I think, Arun, you asked the question, was CRS progressive? It's usually with all of these bispecifics happens in week 1 and week 2, and most of the CRS is a step-up dosing. And in week 2, with the actual full dose, also you get a little bit of it. And I think that was true for talquetamab as well. What was interesting to me was 60% of these patients actually got tocilizumab, right? And the grading of CRS, the rate of dexamethasone was very low, 3 or 4%, but use of toci was very high. So although they reported grade 1 and 2, they probably, and all of us do that at grade 2, we don't wait for the CRS to get worse. We give the tocilizumab quite promptly, and that may have mitigated it from getting to the grade 3 and 4. Certainly with the IV dosing, that's seen a higher grade 3 proportion. I think one of the other big limitations of this study is, yes, it's effective in the relapse refractory setting, but if you look at, and we like to dice the relapse refractory setting as well, this was a less heavily pretreated patient population, right? They were about 60% of them were, 70% of them were triple class refractory. Now, if you look at all the data with any of the BCMA targeted agents, they were 100% triple class refractory, and close to 70% of these patients were penta-refractory as well. So I do think these were less heavily pretreated. The other interesting thing to note here was, if you look at patients who had high-risk disease, the proportion was a little bit lower and not that many with extramedullary disease. So certainly showing efficacy in sort of the back end of myeloma. But if you compare it in the context of BCMA-directed strategies, maybe a less heavily pretreated population, maybe a less high-risk population, so to speak. I think for me, the big thing is management of the toxicities, right? And two really important things which are striking out here, which are going to be different from the BCMA-directed strategies. You saw the infection rate. Infection rate was really low. And I think in the paper also, Annie, they've reported on hypogammaglobulinemia in this. And that is not surprising because you're targeting GPCR5D, you're not targeting BCMA, you're not causing the same level of B-cell aplasia, you're causing the plasma cells to go away, and you're not seeing the same level of infections. There were infections, but most of them were grade 1 and 2. There was neutropenia and myelosuppression, mostly with cycle 1. But again, the grade, if you compare now the TEC data, which is published, and I think you all did a journal club on the TEC data as well, with teclistamab and now with elranatamab, which will be published soon as well. The data for that is neutropenia, thrombocytopenia, myelosuppression in close to 80% of people in the first 2 cycles. Not surprising because is directed against BCMA. This one was less hypogam and less issues with infection. What was a concern here was the dysgeusia, and you showed 70%, and there was weight loss associated with it, right? That means it is significant. People are not eating when they're on this drug. Their nails actually fall off in some situations, and they do get a lot of skin changes. So skin can get better. Nail, it's a hard time for them to get better, and we really haven't figured out a mechanism of how to prevent that. So I think it's great that we have a new target. I think, Hari, you brought up a really important point about 30% of these were BCMA, previous BCMA. We don't know how many actually had CAR T cells. My sense is the majority of them had an antibody drug conjugate, but there's data with Elran as well, where this was pre-BCMA followed by a BCMA, and post-CAR T cells bispecific work. And the reason for that is pretty simple, right? The CAR T cells is one and done, and then they are well for like a year and a half, and then come in. Most times we see that the target is either preserved and the T cell function is intact, which is what is really required for the T cell engagers. But this brings up again a really important question of sequencing when we have all of these immunotherapies. And in my mind, it is absolutely critical that using a bispecific prior to CAR T cells may be a challenge, because you showed us really nice data, Annie. You showed us data on PD-1 expression on the T cells. I don't know what to make of that data. It doesn't make a lot of sense to me. What they've shown is increased expression of exhaustion markers in the T cells. So they're showing that by giving a G protein coupled receptor bispecific, they're exhausting the T cells. So if you're exhausting the T cells and then going to collect these T cells to create CARs, that's going to be a problem. So it does give us, I didn't quite understand the point of the presentation for the purposes of TALC. but it gives us a sense of what we should be doing in terms of sequencing of some of these really novel bispecifics.
Thank you. Thank you for that elaborate insight into bispecific, because we don't have too much experience using these antibodies. And as you rightly said, teclistamab is open in the relapsed refractory setting over here. I was just wanting you to just, if you know, the concept of the sink effect in bispecific antibodies. Could you just elaborate some on that, because we come across that terminology quite a bit.
Yeah, so that way you highlighted it so well, Annie, and that's huge. So this doesn't get shed, right? BCMA, you have soluble BCMA levels. So you have circulating BCMA levels. And when you give an antibody, when you have circulating BCMA levels, that's going to bind to that antibody. And then the effective antibody binding to the tumor itself is going to be decreased. And that is referred to as the sink effect. And you might have to use higher doses to get around that. The other thing which can happen is that this can make it more immunogenic. You can end up with more antibodies and the same stuff. So antibodies to the drug product itself. So the good news with GPCR5D is very restricted to the tumor cell. There's not a lot of shedding because of the nature of the protein itself. And because there's no soluble GPCR5D that we know of, there's no binding when you give the antibody in the circulation. So it just allows for higher concentrations, better binding, and preventing of the sink effect with this. And you also brought up this issue of the gamma secretase inhibitors, right? Why are we using GSIs with BCMA-directed strategies? So that was a great sort of understanding of BCMA. What is gamma secretase? Gamma secretase actually cleaves off certain proteins. Specifically, what it does with BCMA is it cleaves BCMA from the surface of cells and increases more circulating BCMA. What using a GSI does is prevents this cleavage from a plasma cell so that it increases the expression of BCMA on the plasma cell. And by doing so, you're going to help with more BCMA expression on the plasma cell and better binding. We don't clearly have that, and this is absolutely an advantage of the GPCR5D targeted approach.
Thank you, Nupur, for that wonderful discussion on bispecific antibodies. So we can go to the next part of our of this journal club, which is the Eagle Eye in the Eagle Eye competition, wherein we have looked at a critical review into some of the an article, and this time's. And we have put it up for a competition, and it is reviewed, and the results are, I mean, the interpretation and the critical comments are reviewed, and we put it as a competition. And the winner for this time is Dr. Mona Vijayaran from Sahara Hospital, Lucknow. And she will make a brief presentation on the topic. And I hand it over to Nirav to just for us to view a short video presentation on the topic. So I forgot
Good evening, everyone. I'm Dr. Mona Vijayaran. I'm a consultant in clinical hematology at Sahara Hospital, Lucknow, and I'll be presenting the journal scan for February 2023. The topic for journal scan is Minimal Residual Disease in Multiple Myeloma, Why, When and Where. It was published in AS Education Program Book in 2021. This article evaluates that MRD testing, its limitations and how it may fit in with current and future clinical practice is reviewed in this article. We have come a long way from achieving CR rates of 10% with thalidomide and dexamethasone to up to 95% with Dara-KRD without the use of high-dose melphalan. And to better assess these improving responses, MRD testing using more sensitive tools has emerged. What is the importance of depth of response? Intuitively, when we see the depth of response should correlate with the long-term outcomes, but it has to be proven by the trials. In 344 patients which were evaluated in GEM and PETHIMA groups, they noted differences in survival between CR, near CR and very good partial responses. But the ECOG and the Bellini trial illustrated that deeper responses are not always associated with improvement in survival. There are two main methods which are used for MRD testing, that is next generation flow and next generation sequencing. Next generation flow cytometry does not require a baseline sample. Sensitivity has less than 10⁻⁵. It assesses for hemodilution and turnaround time is faster, 2 to 4 days. And on the other hand, next generation sequencing requires a baseline sample as a higher sensitivity of 10⁻⁶ and turnaround time is longer, 7 days. The concordance is high. The choice should depend on the availability and institutional practice. MRD status was seen to stratify patients in CR where overall survival was 112 versus 82 months for MRD negative versus MRD positive patients. These MRD based criteria have been included in the International Myeloma Working Group as sustained MRD negative, flow MRD negative and imaging plus MRD negative. As evaluated, as seen in this diagram, the IFM 2009 was studied to see that there is progression-free survival difference according to the depth of MRD responses. In high-risk diseases, MRD negative response may be even more important. The durability of MRD negative status is similarly important, like seen in Pollux and Castor study and in the Alcyon and Maya trials. The pattern of loss of MRD negativity is also important, which state that there is a clinical relapse for 9 to 10 months. And also in another study which used NGS, the relapse by IMWG criteria occurred at a median of 13 months following molecular relapse. The limitations are mostly three. First is that from a practical perspective, bone marrow involvement may not be uniform. Extramedullary disease may also be present. Like in the Cassiopa PET subset study of Cassiopa, in which 10.5% of patients who were negative by NGF had positive PET-CT. Second is that depth of response may not always be important in all patients, like in this cyclin D2 molecular subtype, which characteristically includes patients with translocation 11-14. The lowest and slowest cumulative incidence of response, yet has comparable outcomes with MRD positive compared with other patients with MRD negative. So it is a challenge on how to identify these set of patients. Third is that there is a requirement for a bone marrow aspiration procedure. So this has motivated other less invasive tools like liquid biopsies. Applying MRD to clinical practice. Till now, there are no prospective randomized data in which the information from MRD can be used to guide treatment decisions, but there are ongoing trials. The two time points where the trials are studying are after initial therapy and prior to starting maintenance. These are the various trials which are testing for MRD testing to guide treatment after initial therapy, and this is the other set which is seeing MRD testing to guide treatment on maintenance therapy. Should therapy change to deepen responses? As responses may improve over time, it becomes difficult, and Auriga study is trying to answer this question. Can we de-escalate treatment? Current practice is not to de-escalate, but there are several trials which are examining, like Perseus and Dramatic trial. And should therapy change if a patient becomes MRD positive? Now we have seen from subgroup analysis of Endeavour trial that treatment at biochemical relapse rather than clinical relapse have better outcomes. So Remnant study is trying to answer that questions. In conclusion, ongoing trials will provide data and guide how to incorporate MRD testing into clinical trials, and functional imaging and liquid biopsies will provide less invasive ways of evaluating disease burden. Thank you.
Sir, you need to unmute.
Yeah, thank you. Thank you for that presentation. It was a recorded one. Yeah, but we did have during a lot of discussion of MRD, and Dr. Nupur, you're one of the you're the author for that talk. I mean, is it time for us to incorporate MRD always in our assessment of the patient to determine the way that we need to treat and what are the in terms of what we need to choose and guide our treatment in the future.
Yeah, so, all good questions. And I think that's where the challenge of MRD is, right? So, as of right now, I would suggest that MRD has been shown to be of prognostic importance. It's a prognostic importance not just with PFS, but with overall survival as well. And it doesn't matter which test you use, as long as you get to a certain level of sensitivity. And based on the IMWG, what we've highlighted is get to 10 times minus 5, whether you use the flow assay or you use the next-gen sequencing assay, it should not matter. So, in this day and age where you're seeing responses even after 5 lines of treatment, where 70% of people are responding, we need a better way of evaluating response. So in my mind, MRD is just a new definition of our complete remission, which used to be complete remission. We need to use MRD instead of CR. Should we be doing it in every patient right now? And the answer to that is probably not, because it's an expensive test. And, we're not really changing therapy because of MRD, or we're not tailoring our therapy as yet. Having said that, I think the future is going to be all about MRD. So if we are not already doing it, we have to be in a position where we set ourselves up so that we are able to do MRD testing. And whatever that test is a choice. If your center can do a flow-based assay and get Euroflow in the mix, that's an easier assay because it's done on fresh sample. You don't need archival tissue, and it is actually able to control for a marrow sample which can be dilute. Of next-gen sequencing assay, we tend to do that, but you do need archival tissue. You need your diagnostic bone marrow to be able to find out what the clone is. You need to be able to sequence that, and it allows you to track the clone. If you compare the two assays, so next-generation flow and next-generation sequencing, they're quite comparable. They track quite well together. Maybe the sensitivity of next generation sequencing is a little bit more. And this was shown in the Cassiopeia trial, where they did both MRD by flow as well as sequencing. But end of the day, I think our suggestion is, as long as you can get to 10 times minus 5, and as long as your institution is used to one or the other assay, I would pick and choose. I think the biggest downside right now of bone marrows is there are several, right? One is it's an invasive procedure. You're doing a bone marrow. 2 is it really is dependent on the person who's doing the bone marrow, because if you get a dilute sample, you're going to be MRD negative. But does that really mean you're MRD negative? Or was it just peripheral blood contamination? That is better assayed on your flow, not so much on the sequencing assay. And the third big thing is, there's a lot of patients, as you become relapsed and refractory, you have less marrow-based disease and more extramedullary disease. So you might have EMD, and you'll be MRD negative in the bone marrow, but how does your prognosis is just as worse. And finally, there's one subset of patients which I think all of us are familiar with in our practice. And those are patients who sort of start off with MGUS or smoldering myeloma, become active myeloma. And then when you treat them, they revert back to that MGUS or smoldering state, and they will never achieve a VGPR or better. Their outcome is still just as good. And this is more specific in patients who have the 11-14 translocation. They do quite well, but in terms of response, they're not the ones who achieve a big CR. And I think this has been taught to us many, many years back, right, by Bart Barloghi, who showed us that with total therapy, there's a subset of patients who go into complete response very quickly. So one would imagine that they are going to do well. But these are the patients who have the highly proliferative myeloma. They go on a CR within a month, 2 months, but they just progress just as quickly. And these patients would be MRD negative at the time of CR and will progress just as quickly. So I think understanding the kinetics of that MRD negativity is going to be what we'll be doing in the next few years. You saw in some of the studies that you described, MRD negativity can happen a year into your treatment. It can happen 2 years into your treatment. And that's why it's hard to make a decision about changing. And that's where I think we brought up the concept of sustained MRD negativity. So when you get MRD negative for more than a year, that is considered sustained MRD negativity. So if it's sustained for a year, is sustained for 2 years better? We don't know that. And some of the studies which were highlighted will answer all of these questions. So the simple answer, which I haven't answered your question, Hari, is that don't do it in routine practice. Set yourself up so that you can do MRD as a practice on a clinical trial. Whenever you're designing clinical trials, make sure you incorporate an MRD endpoint, because that's how you're going to learn from it. And what we are trying to push this MRD for is mostly a regulatory endpoint. And I'll give you a simple example of that. If you look at the Griffin trial, for example, we've used 4 drugs. We've used Dara-RVd. And you look at Dara-RVd versus RVd in transplant, 100% of patients respond. 70%, 60% of them go into a complete response. So you can't discriminate between the two. When you start looking at MRD testing now by next-gen sequencing, the 4-drug arm had a MRD negative rate of 60%, whereas the 3-drug arm had an MRD rate of 30%. Now, this is important because at a follow-up of 4 years, the PFS is no different. It was 88% in Dara-RVd and about 84% in the triplet. Overall survival completely overlapping. But with the difference in the doubling of the MRD, at 6 and 7 years, I am sure that we're going to see a difference. Now, can we wait 6 and 7 years to make treatment decisions in myeloma? We shouldn't be doing that. And that is why what we are pushing for, doing MRD, incorporating it all studies, using it, and actually the regulators are allowing us to use it as a co-primary endpoint because it's an early readout for response for myeloma, which I think is critically important.
Thank you. Beautifully said, Dr. Nupur, and thank you for that. One of the questions that is, when we all know the bone marrow MRD and the PET CT, yeah. So there is a question from Pankaj. Pankaj is online. Actually, he can ask the question straight away. Yeah. So do we have to always look at it differently? And so, which means that unless you know what is there on the PET scan at baseline, we were not able to make routine interpretations down the line. So, should PET scans also be part of the paradigm for baseline evaluation?
I think in India, the answer to that is yes. I was there with you guys a few weeks back, and you all seem to be able to get imaging way easier and cheaper than we can. So I think having a baseline PET scan is really critically important. I think the time to repeat that PET scan would be when you are sustained MRD negative. And if you look at the IFM data, and Philippe Moreau has done these studies on some of the IFM studies where it was done in a subset group, it was called, and even the Cassiopeia has done the Cassiopeia CASOPET study, right? Where you added on to that MRD negativity, PET negativity, and it improved upon the response rate. So certainly using imaging is better. Pankaj, you guys had done functional MRIs instead of doing PET CT. If you all can incorporate functional MRIs as part of your MRD testing with some of your trials, you all will be the first ones to report on this. I'm saying that again. So I would encourage you all to do it, but don't do it at one time point. Do it at baseline and do it after you've seen sustained MRD negativity. I think the beauty of the functional MRI. It's even better than a PET scan because all of us know that not all myeloma is PET avid. It's only the myeloma which is doubling a little bit faster is PET avid, and there may be 15 or 20% of myelomas who stay very PET cold. So it's not helpful in those situations, but a functional MRI would be helpful there.
Thank you. Thank you for that. If there are no more questions, and then I think we should move to the next part. And we have a quiz based on the discussions that has been happened, and I hand it over to Arun to conduct the quiz. Yes.
Good evening, everyone. Yeah, so we move on to this edition of the myeloma quiz. Can I have the next slide, please? So, as is usual, we will have a question on the trivia, 2 on the journal club, which was discussed, and 2 based on the journal scan. The next slide, please. Nirav, actually, what I'm seeing is the screen is too big. Is the screen visible now, appropriately zoomed up? Because what I'm seeing is some part is missing in the slideshow. Okay. So I'll go with the question. So this is about a drug X, which was originally created by Myogenics, a company which was started in 1993 by a group of Harvard professors. And this gentleman by the name of Dr. Julian Adams, a chemist who had worked at 2 big companies, was hired as a chief scientist and a lead. But his initial idea about the drug was to mitigate muscle wasting that accompanies some cases of cancer, HIV, and other diseases. But in animals, the drug had more effect on tumors than muscles. So Proscript, as Myogenics was renamed, began trying the drug in various cancers. And then it decided to focus on multiple myeloma after its first patient with the disease showed a complete remission. Months later, this company is swallowed by another giant called by the name of Millennium, which at that time was primarily interested in Campath at that time. But this was an astounding success and led to an accelerated FDA approval of the drug. And it was marketed by Takeda, which actually earned it a lot. I want you to ID the drug X, which made big fortunes for both the myeloma patients and the company in years to come, once approved by the FDA. I have given you the 4 options. You're supposed to latch on to one. Yeah, the second question. The International Myeloma Working Group and the Bone Marrow Transplant Clinical Trials Network have provided guidance around definitions of MRD and performance. What is the IMWG recommendation regarding the optimal sensitivity of an MRD assay? I think if you have been attending to what has been discussed, I think you know the answer to this question. The next question. Which of the following is an incorrect statement with respect to MRD in myeloma? So MRD negativity in the marrow. What is sustained MRD negativity? So sustained MRD negativity in the marrow and by imaging confirmed a minimum of 2 years apart should define sustained MRD negativity. And as far as image MRD is concerned, the second question is about that. Disappearance of every area of increased tracer uptake at baseline, or if you have a comparison to a baseline PET-CT, or if you don't have a baseline PET-CT, if you see that the SUV uptake is less than the mediastinal pool or decreased with respect to the surrounding tissue, is that what defines image MRD negativity? The concordance of post-consolidation MRD by multiparametric flow cytometry and the NES was 80% in the Cassiopeia. The MRD progression by flow cytometry has been shown to predict biochemical relapse by 4 months and clinical relapse by 9 to 10 months in patient receiving LEN maintenance. So I want you to identify the incorrect statement in this question. So the next two questions are based on the journal article we discussed on talquetamab. So which of the following is an incorrect statement regarding adverse events with the use of talquetamab as per the results of the trial? The most common adverse event was cytokine release syndrome, and all but one were of grade 1 or 2. Hematological toxic effects were the most common grade 3-4 events. The most common reason for treatment discontinuation was progressive disease and not grade 3-4 events. High incidence of pneumonitis in the trial correlates with GPRC5D expression on the lung tissue. Last question. Which of the following statement regarding response rates to talquetamab in specific myeloma subgroups is incorrect with respect to findings of the monumental trial? So this is actually right from the supplementary appendix. If you have gone through the appendix, you may cast this answer. So stringent CR in triple refractory group was 25%, a VGPR and above in extramedullary plasmacytoma of 20%, a VGPR of and above in a pentarefractory group of 50%, a VGPR or above in higher cytogenetic group of 30%. You're supposed to identify the incorrect statement. Thank you. With the permission of the host, I will discuss the answers before we declare the result.
Yes, please go ahead.
Can I have the next slide, please? So this was about the drug X, and we discussed it moving from one company to another, and finally it finds its way out. And this is our own Velcade or bortezomib out of all of these. Can I have the next slide, please? And when we discuss bortezomib, we must pay respects to this gentleman by the name of Gillian Adams, whose ingenuity actually brought about this drug and revolution in myeloma care. He is a PhD in synthetic organic chemistry from the MIT, and presently is a CEO of Gamida Cell now. And while he was the director of medical biochemistry at the Boehringer, he actually went on to discover nevirapine in HIV, which was one of the backbone of HIV therapy in the beginning, and close to 40 patents under his name. Can I have the next slide, please? So this was straight from the discussion and the point alluded to by our international expert. So when we have an MRD assay, depending on whatever platform you use, the minimum recommended is 10 to the power of -5 to make meaningful inferences about the MRD. Next question. So this is about incorrect statements with regard to MRD. Again, as alluded to by the presenter, when we define sustained MRD negativity by flow or NGS, it is minimum of 1 year apart as of now. That would define sustained MRD negativity. The other statements are all correct. Even the concordance between the two, whether you use a multi-parametric flow or the NGS, there was a subgroup analysis of the Cassiopeia trial, it was close to 80%. And as discussed, progression of MRD can actually antedate biochemical relapse and clinical relapse. So we can actually be monitoring patient more intensively and catching up and intervening. The next answer. This was about adverse events with talquetamab, and you were asked to identify the incorrect statement. So the incorrect statement here is the incidence of pneumonitis in the trial correlates with GPRC5D RNA expression. In fact, this receptor is hardly ever expressed on the lung tissue. Although in RNA sequencing, there was very low level of expression on lung tissue, and therefore the incidence of pneumonitis was very low in the trial. The last question. So this was about the response rates in specific subgroups. The answers with respect to the triple refractory extramedullary plasmacytoma and the penta-refractory group were correct. But the incorrect statement was in the high-risk cytogenetic subgroup, the VGPR responses were close to 60%, although there was it was a very small subset to be powered for any meaningful interpretation. Thank you.
Hello, Arun sir, can you hear me?
Yes, Neerav.
Sir, we have the winner is Dr. Ankit Jitan from Apollo CBCC Ahmedabad.
I think I'll request Dr. Hari Menon to announce the winner.
Congratulations to Dr. Ankit, and it's always nice to see there's a lot of attention over there, and this particular competition has got a popularity. Congratulations to you to being the winner for this competition. Before I hand it over to Joseph to make his concluding remarks, because we are already beyond the time, I would profoundly express my thanks to Nupur for making this, giving all the inputs and making this discussion so lively and productive, and of course to Annie for giving such a beautiful presentation and comprehensive presentation. Yeah. Joseph.
So is Dr. Pankaj there? Dr.
Yes,
Pankaj
Dr.
is there?
Pankaj.
Or
Yeah, Joseph.
yeah,
please
so
go
why
ahead.
don't
Yes.
you give the concluding remarks?
That's-
Pankaj.
No, so that's okay. I think we had one of the fantastic journal club today, knowing the nitty, very small intricacies of the talquetamab trial, and followed by the discussion on MRD. I think the resident and the fellows who are listening to this journal club and journal watch probably now have a good understanding of the drug as well as on the MRD. And I again really thankful to Dr. Nupur Raje and Dr. Hari Menon and all other who participated in this journal club actively. Thank you so much.
I
Thank you.
just want
As
to
the sun is
congratulate.
rising.
Yes.
I just
Yeah.
want to congratulate all of you and thank you. This was a really well structured journal club. Thank you for including me. I appreciate it.
Thank you. As the sun is rising in Nupur's place, it is setting down and we are all going for break.
You're all
We
going
can
to
see the sun.
retire and I'm going to go to work.
Yes.
I'm in Miami
Yeah.
actually.
Yeah.
I'm in sunny Miami for a meeting right now. So I have to go down
Okay.
and give my talk.
Yeah. Okay.
All the best.
Thank you.
Thank
you.
you guys.
Thank you,
Thank
ma'am.
you
Thank
so
you.
much.
Thank you.
And congratulations,
Okay.
Annie. That was fantastic.
Thank you so much, ma'am.
Thank you. Thank you. Thank you
Bye.
so much. Yeah. Thanks.